I'm Dr. Lucy Ingram. Tonight's second case is a presentation of obstructive sleep apnea in rural general practice. Discussing the case tonight, we have an expert panel consisting of Dr. Jim McConochie, a rural GP and medical educator with QRME, Dr. Ross Sellars, Senior Staff Specialist and Respiratory Physician with Queensland Health at Toowoomba General Hospital, and Faye Barker, Clinical Respiratory Nurse and Sleep Case Manager with St Vincent's Private Hospital and Genesis Sleep Care. Please welcome our specialist and expert panellists. As usual, we are being live streamed around Australia. We have a number of participants watching remotely, so I encourage you all to join the discussion by emailing your questions to grandrounds@qrme.org.au, or you can tweet your questions using the hashtag now on your screen. Our presenter tonight is Dr. Jamie Ware from Warwick. Please put your hands together for Jamie.
Thank you very much for that, Lucy, and thank you very much to our panel for coming along this evening. Now, for those of you who don't know me, which is probably most of you, I work out at the Warwick Hospital, and I work part-time at the hospital and part-time down at the GP practice. So our case this evening gets to see a little bit of both sides of rural medicine, and perhaps shows us that obstructive sleep apnea, which perhaps most of us might see as a little bit of a less exciting topic, can also bring a little bit of excitement into our lives as well. So firstly, I'll give us a little bit of background to sleep apnea just briefly. So the definition is cessation of airflow for more than 10 seconds in the presence of continued respiratory effort. Involves the intermittent narrowing or occlusion of the pharyngeal area of the upper airway. Oftentimes we see that as snoring or hypopnea, sometimes apnea altogether. Generally, it's brief cyclical interruptions of ventilation lasting 15 to 90 seconds. The result of that being hypoxemia, hypercapnia and respiratory acidosis, and patients basically waking up and falling back asleep again and waking up, never getting a good night's sleep. So if you look in the diagram up on the screen, you can see the normal airway there, and then in obstructive sleep apnea, the soft tissues at the back there, occluding the airway and stopping people from being able to breathe, and then therefore causing to wake up and not get a good night's sleep. And this is a very common condition. We estimate 9% of women and 25% of men have got clinically significant obstructive sleep apnea. Only 4% of them are symptomatic, so many of those go undiagnosed. Obviously, males are greater than females, and that increases with age, and increases significantly with obesity as well. And so with our current obesity epidemic, we can expect to see a lot more of this. And I guess the question then is, why do we care about this if so many people have got it and nobody's able to tell that they've got it? Why is it significant? And okay, it's not very often you hear about someone dying of obstructive sleep apnea in the night, but it does happen. But there are a lot of sequelae that can cause significant morbidity and even mortality. Basically a 2.5% increase in mortality rate for patients who've got obstructive sleep apnea. They're 4 to 9 times more likely to be involved in a motor vehicle accident, and the financial burden of the disease is $2 to $8 billion per year. So that's a lot of healthcare costs, a lot of lost productivity, quite a lot of road accidents as a result of that, and also work-related accidents as well. Risk factors, obviously obesity, particularly around the neck and the airway areas, large neck circumference. Age over 65, although it can happen at any age, right down to quite young people. Family history of obstructive sleep apnea or sleep-disordered breathing, some facial abnormalities, smoking, excessive alcohol consumption, and particularly patients who are taking sedatives at night. And the signs and symptoms most of us would know: snoring, gasping, snorting, excessive sleepiness, lack of energy, falling asleep during the day or having little nana naps. That might put a lot of our medical students in that category. Disturbed or restless sleep, poor memory and concentration, headaches, dry mouth, irritability, depression, anxiety, increased frequency of urination during the night, or rapid weight gain or difficulty in losing weight. So that description probably covers quite a lot of the patients that we see quite regularly in general practice. Comorbidities that are associated with it: obesity, obviously, cardiovascular disease, diabetes, insulin resistance, hypertension, insomnia, cognitive function and quality of life, mood depression and erectile dysfunction. So now, a case study this evening. One of the things I love about my job, being able to work in the hospital system and in the private practice as well is that you get to follow your patients through from beginning to end. You get to see them in different types of settings and then follow them up afterwards. And so this patient was a 62-year-old male presenting for a colonoscopy. You come along and do your routine thing. You might have 6 or 8 patients on your list for the morning. You look from the end of the bed and you go, oh, gee, he's a bit big. Who was the guy that let this guy through anaesthetic clinic? And you silently mutter a couple of curses at your colleague and then kick yourself thinking, well, that could be me next time. But this particular gentleman has a large tongue, a Mallampati 3 airway. During the procedure, the anaesthetist is really struggling to keep the patient breathing and tries lightening him a little bit, giving a bit of jaw thrust, a bit of chin tilt, really struggling despite that. In go a couple of nasopharyngeal airways and a Goodell's, and the procedure goes without events. But a little bit concerned at the level of obstruction that he's getting during the procedure. A little bit of desaturation, nothing too significant in terms of causing negative outcomes, but certainly causes a little bit of excitement for the anaesthetist that he didn't particularly want on that nice, easy colonoscopy list for the morning. In the recovery area later, the doctor asked the patient a few additional questions, but as you'd expect, they're a little bit drowsy and not particularly coherent and giving a few vague and slightly high answers. And so rather than follow that through to its logical conclusion, the decision's made to make an appointment and bring them back to private practice the next day. Now, in the GP clinic the next day, we'd have a little bit more time, take a little bit more history. So 62-year-old male, as we said, a smoker, hypertension. They're on Mycardis for hypertension. They're on metformin for their type 2 diabetes. They are on Pariet for a little bit of reflux. They take Zoloft for depression and a little bit of temazepam every now and again, which they say they don't use that often, but when you go back and look through the script history, you notice that script seems to get printed off by colleagues over the phone a little bit more often than what you really think it should be. And going through the past history, you also notice some scripts there for some Viagra and Cialis. Now, when you take a little bit of history directly off the patient, they tell you, yeah, look, the wife does complain about snoring lately, and then the wife chimes in and says, all the time. He's got restless legs and seems to be all over the bed all night. She says that she's seen him choke a few times in his sleep. He's a truck driver. Admits to using quite a bit of caffeine at times to stay awake at night. Works regular night shifts, and that isn't likely to change anytime soon. It's just the nature of the job that he's got. He often feels tired and flat during the day and just assumes that that's because he does a lot of night shifts and has such irregular hours. Gets quite frequent headaches, which he usually just takes a Panadol for. Usually worse in the mornings and worse still if after he's had a night shifts. And looks just like your metabolic syndrome type of patient. Has struggled to lose weight for years, is quite round around the middle, has quite a bit of flab around the neck area. 104.1 kilograms, 159 centimetres, which works out to a BMI of 41.2, which makes you straight away asking yourself why we were doing that patient in a rural environment in the first place, but these ones do slip through from time to time. Waist circumference of 117 centimetres, neck circumference of 48 centimetres. So quite large in both those areas. When you examine their chest, they've got reduced air entry, sort of across the board, and a little bit of a mild wheeze, but not significantly reduced. Heart sounds are fairly normal, perhaps a little bit soft, a little bit of mild epigastric tenderness. Difficult to visualise the back of the throat, even with the tongue depressor, and the reduced neck range of movement as well, which is a little bit concerning. So, in the context of all that's going on, you make the logical decision and send them off and get a sleep study. Sleep study comes back with the result that you can see up on the screen at the moment. So 55 apneas, 53 obstructive and 2 central. And I guess from the point of view of the end point, the conclusion, moderately severe obstructive sleep apnea with moderate sleep fragmentation and moderate oxygen desaturation. Increased during REM sleep. And so the recommendations by the report were sleep or thoracic physician review, Cpap study was recommended, modify the reversible risk factors, and assess their sleep hygiene issues. The spirometry there is up on the screen as well. Basically shows a mildly restrictive pattern, not a lot of obstruction in that. So the patient is sent away, they get their Cpap study, they come back with a prescription. And the questions that they ask is, okay, I've got this prescription now and I had to go all the way into the city to get that, and I've come back and they've handed me a sheet of paper, great, what do I do with this? Which was a fair question, I thought, given that we're now back in Warwick and the patient has come back and they don't have a Cpap machine, what do they do with that prescription? they chime in and say, this isn't going to affect my licence, is it? And they say that's a question that I'm going to throw out to the panel as well for this evening. And the other question is one which the patients themselves asked. A couple of months later, they were down in the hospital, and you bump into them on a ward round. And they're in there with a pneumonia, and the patient's wife comes up and says, we never did manage to get that machine. It was a little bit too expensive. It was going to involve trips out of town and quite a lot of messing around to get that sorted. So we bought one off the internet instead. It says it's an automatic one. It calibrates itself and adjusts itself online, and it all seems like this whiz-bang thing. That should be just as good, shouldn't it? So we'll turn to our panel and let's see if we can get some input on those questions.
Thanks very much, Jamie. I'd like to give you a quick round of applause. I think that's a great place to start. Where to begin, though? Perhaps with the question about the licence, because that is a big one that comes up, if that's all right.
It's a very difficult one, isn't it? I guess what we're really looking at is partly how severe sleep apnea is, but really what the effects are, how sleepy they are during the day, whether they've got a history of drowsiness driving is very important. And also particularly if they've got a history of motor vehicle accidents relating to drowsiness or inattention. And if they have any of those sort of features, then absolutely it would affect their licence. It doesn't necessarily mean that they can't drive, but it means that their sleep apnea needs to be adequately treated before they're allowed to continue to drive. And the benchmark for a commercial driver such as this is actually much higher than it is for someone driving a normal motor vehicle. And that's largely because of the risk that it entails. That it's if someone's have an accident in a large truck, they can cause a lot more carnage than they can in a small motor vehicle. So it's really looking at not just the fact they've got sleep apnea, but how much effect it's having on their day-to-day activities, on their ability to function during the day, and particularly on their driving. So in this sort of situation, what we generally do is advise the patient that they need to notify the transport department. So most times we don't necessarily notify the transport department directly, and in the end it's up to them. There are occasional circumstances where we actually need to notify transport, and that's really where there's someone that's something such as a school bus driver or something like that has significant sleepiness and has had minor accidents from drowsiness but refuses to use their Cpap. Most people in that situation will actually see sense after a while. I've never had to notify the transport department directly, but I've certainly had to write a number of letters and give them to patients saying, if you don't use your Cpap and you don't prove to us that you're using the Cpap, then we'll be sending this letter off. And that generally works for most people.
Great. I was going to say, there is actually a resource for GP registrars. Are you able to talk a little bit more about the assessing fitness to drive? Yeah,
so I think most people are probably familiar with the Austroads guidelines, the fitness to drive document, and that was, so the latest version was put out in 2012 and revised in March last year. And that sets out the criteria that we normally use when we're assessing someone. And the criteria are basically the ones that we mentioned before. So it's a history of sleep apnea with significant daytime sleepiness, a history of sleepiness-related accidents or near misses, significant and frequent drowsiness while driving, and the last one is a bit more nebulous. It's where the medical officer is concerned that they're at significant risk because of their sleep disorder of having an accident, and that's a lot more difficult to sort of pin down that last one. So there are printed documents around, but it's very easy to get from their website, from the Austroads website, and it's something that we refer to on a frequent basis because it's impossible to remember all the different criteria for all the different situations.
Very good. Any comments, Jim?
Can I address the licensing from a point of GP? I think that question should come up before they even go for the test. I think you're obliged to warn them that should this test become positive, you will then need, which then affects your second question about the internet achieved thing, but this will affect your commercial licence should you be positive. With this gentleman, though, you can threaten his licence even before he goes to the test because he has diabetes, hypertension, a BMI, his flexibility in a truck is not good. So you could threaten not to give him a licence if he doesn't go for the test. But I warn them before they ever go to the test. And I usually have the wife present because they're the best help I have to get them to go.
So do you think that would, put people off having the test? And
No, usually when their wife tells them that she'd miss them if he had a heart attack, they're quite happy to go.
It's very commonly the wife is the one pushing them to the appointments and pushing them to the studies. That's, absolutely right.
I was going to jump back in with sort of how common is this as a presentation in general practice, patients with sleep apnea?
I think it's very common. I'm seeing more and more of it, and more of it in younger men. We're seeing, 60% of commercial truck drivers are obese. We're seeing an epidemic of obesity, an epidemic of diabetes, and epidemic of erectile dysfunction. I'm sure a lot of them have it that we don't even think about. We have to constantly keep it in the back of our minds.
Yes.
I would probably send someone for a sleep study once or twice a month.
Yes, because I was going to say, how often do people present saying, I'm snoring or I'm, waking up gasping for breath? They don't tend to do that, isn't it?
They're unaware of it. It's usually from other symptoms that it comes. It depends on a suspicion in the practitioner.
So for registrars watching, what are some of the questions that we should ask, or is there any kind of screening we should do on our patients that fit that kind of profile?
I think there are some set questionnaires that are talked about. I'm not familiar with them. You may well be familiar with them, but they basically encompass many of the symptoms Jamie talked about in this case.
One is the Apnea Sleepiness Score. So that's a score with 8 criteria, and you score whether you're likely to doze, moderate chance of dozing, high chance of dozing, and anyone who scores 10 or more out of that, 10 out of the 24, should actually be recommended to go for a study. There is actually, on the back of the Genesis referral forms, they actually have a screening tool that's available for practice nurses or to use in general practice, where they can actually go through and score the patients there and then recommend a study from there.
And those scores have been validated, haven't they, I understand?
Yes, they have. I don't know.
It's the Berlin criteria, the Berlin questionnaire, isn't it, that they're using?
Yes.
That's been quite well validated. But really, I guess, in effect, it's really people that are sleepy with a history of snoring. They may or may not have witnessed apneas, they may or may not have nocturia, but if they've got significant sleepiness, then it's worth actually considering it.
So let's talk about sleep studies, because that would be, obviously, if you've got this suspicion, you're thinking, should I send this patient for a sleep study? Let's just start with, should all patients that we suspect have a sleep study?
I guess it's looking at what's the risk, isn't it? I think if you seriously think they may have sleep apnea, then it's really the only way to know is to do a sleep study. There are lots of other things, obviously, that cause sleepiness, and sleep phase disorder. There's a whole range of other sleep disorders, and students that stay up studying all night and then can't wake up in the morning because they haven't had enough sleep. Those sort of things are very, very common, or the neighbour's dog barking, or the sore joint that causes a lot of arousals at night. But in the absence of another identifiable cause, and particularly in people that are truck drivers, where the consequence is much higher, your threshold is much lower for doing a sleep study. So I guess by the time someone gets to see me, they almost always go and have a sleep study because they've already been filtered out by the time we get there. Someone with some mild sleepiness, probably not. Someone with sleepiness that's affecting their day-to-day ability, having issues with driving, then absolutely I'll be doing a sleep study.
And do you have any preference or comment, perhaps yourself or Faye, about the different types of sleep studies, whether they're done in a sleep lab or done at home?
There's been a progressive shift over time. So initially they were all in laboratory studies. I think recent data from the US previously it was 70-30, 70% of sleep studies done in centre and 30% done in homes. In the last year that's actually flipped around the other way, so there's only a third are done in centre now and the majority done at home. In the US that's largely because of the funding model. In Australia there are increasing number of home studies being done, but that's largely to manage demand because we don't have the large number of centres that are doing in-centre sleep studies at the moment. It's really a matter of selecting a patient, I think. There's a large group of patients that obviously have sleep apnea, and so we do a home study really just to confirm that's the case. There's a number of patients where you're really not sure, or some of the commercial drivers where if you don't get a good study at home, you're just going to have to repeat it again as in-centre, and often those will send to have in-centre studies. But people with sort of blindingly obvious sleep apnea, the home study will tell us what's going on and will allow us to proceed and get it done a lot quicker than you would elsewhere.
And Faye, did you want to add to that at all?
No, I'm very happy there. I think probably when a GP speaks to me, particularly about where they should have a study, I usually look at if they've got comorbidities. If they've got comorbidities or the medication they're on, whether they're on narcotics or on sedation, then I do recommend they're probably better done with a formal study, just like Ross has said there, because you'll get the first study done and then they'll end up having to have another formal study in hospital. But for our area in particular, we don't really have a public facility to study, so patients need to go through to Brisbane, so it's that tyranny of distance again. We do have local in-lab facilities for private, and we also do have home studies locally.
Okay.
And then in Brisbane we have the facility also for non-insured studies. So I think it just depends on the patient, and Ross is right, it's about getting them studied. If you know that that it is obvious and you want to treat them, and you need to get them on treatment. And sometimes we'll actually see them and not even without having a Cpap study, so their titration study. So they may actually have a diagnostic start on therapy and then go in for their titration study to follow.
Yeah, would you like to talk a little bit more about that, Faye, about how that works for your patients and what you do with them?
So what we actually do when they're diagnosed, and this is a pretty moderate sort of case that we're actually presenting tonight, because we can actually see a lot more events than that per hour, some in the vicinity of 50, 60, 100 events an hour. So sometimes on the study results they're barely breathing. So we will actually, or they may actually present in respiratory failure within the hospital setting as well. So we'll actually put them in, do a diagnostic study, start them on an automatic machine, which leads on to one of those other questions there, but there's a lot more to that question than buying the automatic one online. So we might actually start them on an automatic machine, which basically allows us to set a minimum pressure and a maximum pressure, and then the machine will actually auto-titrate between that minimum and maximum pressure. A stock standard type of a script is like 4 to 20. I'm not sure that I agree with all of that, because sometimes people need their pressure much quicker than that, so that 4 centimetres of pressure can actually be quite low. But that machine does get us from most of the machines that we have now, they have a little data chip in them, so we can actually download that in a day or two, or after they've had a couple of nights on Cpap, pop it into the computer, and we can tell their disturbance index, their how long they've been on the machine, how their mask is fitting. So there's a lot of good data, above compliance data, that we can actually get from those machines. And from there, we then put them onto a trial of a fixed pressure, but you don't actually get oxygen levels. There are adapters that you can actually put onto the back of some of the machines, and we can actually get printouts of their, if they are maintaining saturations, but otherwise you really do need to put them back into the lab for the Cpap study or the Cpap titration, where we can determine the pressure that best suits this patient. That's something we really can't do in home studies. So as far as I'm aware, the only Cpap titration studies need to be done as in hospital patients.
Right. If I can take a little step back just to having the sleep study done, and then supposing that goes back to the GP, which it often does, prior to their specialist review perhaps, what does the GP registrar need to look at with that reading? What's important in that report? Jim or Ross?
I think the most important thing for me is usually the recommendations at the bottom. And then if I've read recently, because I'm coming on this thing, I might know what an AHI is and what these things are and what mild, moderate and severe is. But firstly, the recommendations on the bottom. And then the clinical picture of the patient. The importance of that patient getting treated, if they're a non-commercial driver or commercial driver, or what their job is, or what their other symptomatology is. So you've still got the patient in front of you, that's important as well. But certainly the recommendations on the bottom, and whether that's called mild, moderate or severe, whether you forget whether the cut-off is 15, 30 or 40, whatever, and follow the recommendations on the bottom, I think.
Do the recommendations invariably say a specialist review is recommended?
Not always. Sometimes you will get mild sleep apnea, and this comes up with whether it's central or obstructive, and they now do studies with them supine on their lateral positions, things like. Sometimes you get them recommended for alternatives to Cpap, such as a mouth device or some sort of device, and so not everyone needs a respiratory physician. Others I personally think if they need a Cpap machine and they're a commercial driver, they have to have a respiratory physician anyway, because that's mandatory to get their licence. So, yeah, it just depends on the recommendations on the bottom.
Great.
Yeah, I think your point of looking at the patient is very important, because the numbers are purely arbitrary, and just because someone has 30 events an hour doesn't mean they've got severe sleep apnea. They might have a severe study, but doesn't mean their sleep apnea is severe. So looking at how much effect it's having on the patient is very important. I guess what we tend to look at is what's the quality of the study first, so how much sleep they've got, what the recording's like, whether they get whether much REM sleep and particularly much supine sleep, because they're the times when sleep apnea is the worst. So particularly in a truck driver, if you're looking at excluding sleep apnea, if you have a good period of supine REM and you don't have many events, then you can be very confident that they don't have sleep apnea. You don't need to go any further. Whereas if your study doesn't show that, then there's always that bit of a question mark as to what's going on.
Okay. I was just going to ask about treatment options, because I think there's a general feeling in the community that if they're diagnosed with sleep apnea, they're going to have the mask, and a lot of people are very, wary or frightened of CPAP. Sort of, what are some of the treatment options? CPAP's obviously one of them. What else is available?
I guess there's a lot of options, and it's really a matter of tailoring it to the right person. CPAP, we know it's been around for a long time, and there's very good evidence for its effectiveness in sleep apnea. It's reducing motor vehicle accidents and reducing long-term morbidity and mortality. A lot of the others we don't have data on. Mandibular advancement splints, I think Jim mentioned, are used from time to time. They're probably best in people with fairly mild sleep apnea that have a lot of symptoms. At best, they might reduce the number of events per hour by about half. So in that group, what we'd often do is, so they need to get the device fashioned, and then usually we'd have a study with the device in to show that it's actually effectively treating their sleep apnea. The problem, I guess, which is different than CPAP, is that it's not something you can hand back if you don't like it. You can't reuse the mouth guard. So they're really stuck with it and with the cost of it. They can be a bit uncomfortable as well, because it really advances your lower jaw by about 1 centimetre forward, and it's done progressively over time. So essentially dislocates your temporomandibular joint and moves it forward. And a lot of people can get pain in the joints, and it can cause a lot of salivation as well. So it's not for everyone. Surgery, there's select groups where surgery is very good. The old U-Triple-Ps and things are good for snoring, but really don't do much for sleep apnea. But there are certain people with craniofacial abnormalities where it makes a big difference. So huge tonsils, for example. You see some people with big golf ball tonsils that are nearly touching in the centre, and they can do very, very well having the tonsils removed, and then when you repeat the study afterwards can show that their sleep apnea is largely gone. Similarly, people with a lot of nasal obstruction, sometimes nasal surgery and reducing that obstruction, improving the airflow through the nose, can be enough to turn their sleep apnea from being quite severe to being quite mild. I suppose they're probably the commonest things. There still are people having other sort of surgery and things on the throat. A lot of that's unproven at the moment, I guess. But probably the main options are really CPAP if you can, mandibular splints in some people. The other thing we sometimes do is body positioning. Sometimes when you look at a study, you might see someone that has quite severe sleep apnea on their back when they're supine, and when they're on their side, they may have quite mild or normal sleep. And in that setting, you can do things which actually force you to sleep on your side. So it's not something you can do consciously. You need something behind, something around the back. So if you have very heavy pillows, can sometimes work. The old-fashioned snoring remedy of a tennis ball sewn in the back of the pyjamas is actually very, very effective. I've even had someone whose wife sewed a pine cone in the back of their pyjamas to stop them lying on their back, and it's not something I'd sort of generally recommend. And there's a commercial product which sort of looks like an inflatable bra around backwards that has these pillows that inflate that stop people lying on the back as well. So it's a fancy tennis ball, but that can work in selected patients as well. But it's choosing your treatment for the individual.
Okay. And once you've got some treatment underway, what sort of follow-up should a GP be doing, and sort of how does that work in terms of with the specialist? What sort of, is it a team care arrangement, or how does that sort of flow?
Yeah, I guess it depends on how comfortable people are, and I guess not a lot of people have had a lot of experience with sleep and with CPAP, so it really depends on how familiar they are. what most sleep centres tend to do, and certainly don't do what was mentioned on the slide here of giving a script and sending away. You know, if a sleep centre does that, I wouldn't send a patient back to them. That's quite poor form. We know that first month is very important in establishing people on Cpap, and it's something you'd have a lot more to do with than I would. But the amount of time that's invested in that first month is crucial in getting them to continue long term. Once you get to 12 months, if you have a good understanding, you can manage the Cpap, you can adjust things yourself, people will do very well. And the evidence is if you get there and you've got good adherence, then you're going to do very well in the long term. So most centres would follow people out to about that 12 months and then usually, if they're non-commercial drivers, discharge them at that stage and see them if they need to, which is usually when the machine breaks down in 5 or 10 years.
And did you want to talk a little bit about
a compliance program, exactly what Ross is talking about there. So if we actually get a referral, and when we get our referral, so they'll come with a script, or most of our referrers will actually phone us and they'll straight away make an appointment for that patient to come straight across. So we actually hold spots within our clinic with the physicians that we work with, so if they see new patients at certain time slots on certain days, and in the clinic we hold a spot to follow. So the patient goes, sees them, gets the results, then they have the option of coming straight across to us. They have an option of other places as well. They aren't always referred to us, but we do have that timely referral and timely seen. So then when they come across, we have a program, it runs over 2 months, so they have a rental. So they don't just go and buy a machine, you actually rent a machine, and you rent a machine for 2 months. And we show in that 2 months, we see them at setup for at least an hour. That we reinforce the education, we find out what they've understood about their study, and then we take them forward. I use the analogy often that as soon as you come in with someone with sleep apnea, I say to them, you're driving your body like you would be driving your car on a flat or a half flat tyre. And I start from there and then work through what their options are to treat that, and show them different machines, different masks. They have time on a machine, time on a mask, because each of the machines has a different algorithm inside. So with some of them, different manufacturers will have the pressure rising quickly, and falling quickly. Others will have a more subtle rise with a more subtle fall. And just the way that people are built and the way that they tolerate those pressures depends on which machine. They have comfort settings in them now. Back 20 years ago, people would say, I can't stand that pressure, I can't stand that mask. And I do think that we were actually putting people on much higher pressures then than I'm probably seeing as much of now. But now we have relief pressures in machines. So if someone needs a pressure of 15 centimetres, they can breathe in against 15, breathe out against 12. So we have relief pressures that'll actually drop against their expiratory pressure. And we're talking just really about treating obstructive sleep apnea tonight, because there's a lot of different machines if we're looking at central or patients with cardiac problems. So then for these patients, we set them up on that rental machine. They then go home. We phone them in a week, but they are always given a phone number to actually contact us if they're having problems in under that time. We see them back 2 weeks later at 4 weeks, 6 weeks and 8 weeks. Now, obviously, if they're from out west, they have little data cards. They send them in. We download that data and we phone them. And some of the staff are away having education tonight, because very soon we're going to go wireless. So the new machines that are being released at the moment will have a wireless network, which means that if the patient has this adapter onto their machine, we'll actually be able to remote in. They'll be able to press a button on their side. We'll be able to pick up the data here, and we'll actually be able to adjust and change their pressures from our centre.
Oh, that's really great technology, isn't it?
I think I think it's going to change the process and the plan for some of our rural people. I think it's going to be a big advance.
What are some of the common problems that people present with when they've got their new Cpap machine?
Absolutely. Some of it's tolerating the pressure, and again, you mightn't get to the ultimate pressure right off, so you may actually have to reduce that pressure till they settle on it and then titrate that pressure up. Other common problems will be masks get put on far too tight, so they'll think that the air flowing around the face is actually an air leak, a mask leak, so they'll tighten the straps, and they never tighten them just a little bit, they just rip them really tight because they're just going to get off to sleep. So therefore, understanding that a minimal adjustment to headgear can actually make a big change in the seal on the mask. Others will be breathing cold air or get nasal congestion, so there we need to have warmth and moisture, so their air pressure needs to run over humidification. For some people it is just the style of mask they're given, and when we do a study in the overnight lab we have one night to get a mask fit right. So with the service we try to actually mask fit people before their study, so they actually come and see us for a half an hour before they go for that study to determine the pressure, so they've got a little bit of an opportunity to try what Cpap is like, and then a trial of a couple of different masks, and then at the study that night they'll use one or two of those masks, and then when we follow up later we'll give them more than one mask as an option for their home equipment. So I think they're probably common ones. You do get pressure sores if people actually put masks on too tight, or if the size is uncomfortable. So leak is a common problem, but not if the mask is fitted well at the first setup.
Okay, that's great. I also say we have had just one question about cost. That seems to be one thing that also comes up a lot. What sort of things do people sort of look at in terms of cost of machines?
Cost of machines, I mean, I think the bonus of having the rental system, and then that rental actually comes off at purchase for people. So that's within our sector, which is great. And even if our patient then goes on to the public sector and are eligible for a government machine, so I think it's important that people know that that system is there. And Ross may want to talk more about that government system, but as my understanding, they do need to show 2 months compliance, so they actually rent that machine and then can get their machine that way. The other options, I mean, machines, a basic Cpap machine is around $800 or $900. You add a humidifier to that, so you're looking at about $1,500 on a basic machine. And then when people start to just go and buy automatics or don't trial fix, they can add another $900 to $1,000 on top of that. And a mask anywhere between $200 and $300. There's always payment plan options as well, so it's not a matter of just this cost up front. There's other ways that we can actually make a machine affordable for a patient. Then the other thing also is that if people have private health cover, they may well then be eligible for a rebate back from their private health cover. And people, I don't think that the general public understand that fully, and so it's important in the services like that we run that we actually alert people to those options, because if it's going to make the difference between being compliant and having a machine, or to even buy one online, because when you buy online, then if there's a problem, you don't have anywhere to go back to, and it may not be the right machine. Whereas if you've rented for 2 months, you can see the data, you can confirm it's the right machine before they purchase, so you don't waste the money.
For sure. Anything that you wanted to add?
So just a couple of things. One is I'd certainly reinforce that hiring the machine first, because it's not for everyone. Even we know that we can treat pretty much everyone's sleep apnea with it, but the issue is, of course, there's a patient involved in the interface and all that sort of thing, and it's so hiring the machine so they don't end up with an expensive door stopper if they're not going to use it. The Queensland Cpap program is run through. So in our region, it's primarily Princess Alexandra, Royal Brisbane, and Prince Charles. And for anyone that's a pensioner or a healthcare card holder, may be eligible for Cpap funded through that. It means travelling to Brisbane for at least the pressure determination study, and then a 2-month hire, and then seeing them again after that and they'll download the compliance data from that and then provide a machine for them. That's again for standard Cpap, and for other conditions then there are other criteria, but in the Queensland Cpap program, they still need to buy the tubing and mask, so that there's still a $200 to $300 depending on what they look at. So it's not completely free, but at least the cost of the machine is covered by that for eligible patients.
And so what do you all think about that last question with the patient that, it's just as good, isn't it? The one bought online? And how would you then go forward, I guess, from that, assuming that it's perhaps not the right machine for this patient, or may not be the right machine?
It's difficult, isn't it? I guess the problem with this is that we don't, it's not compliant with Australian standards, so we don't know about even simple things like electrical safety, and if they have a humidifier, if there's water spillage, there is potential for significant risk. And it may be fine, but you just don't know. And so it's very, very difficult. I guess if they do, they probably need to make sure it gets tested by an electrician to make sure that it's actually safe. we can certainly measure the actual pressure it's delivering rather than what it's saying it's delivering, so we can actually measure that and make sure it's effective, as most centres can. But I suppose it's buyer beware. You know, you really don't know. If it's working fine and it's safe, then great, but you just don't really know. And I suppose the question is why can't they afford it? And unfortunately, so there are some people that can afford a private machine without any issues. There are the pensioners and things that are eligible for the Queensland Cpap program, but there is a big sort of gap in between that where people don't quite qualify for the funded program, but find it very difficult to fund the machine themselves. And I think that's the sort of people that are very tempted to do this.
For sure.
Do you have any comment about how you tell if it's safe?
No, I think exactly what you've said there, Ross. I think the biggest issue for me is buying the wrong machine, the wrong type of machine, and you can actually outlay more money buying an automatic when you may actually well have got away with a fixed. So if they actually only needed a lower pressure, and I believe there is actually even some work that's being done cardiology-wise that actually says that delay in getting up to that higher pressure can be more harmful, and they can actually be also more hypoxic before the pressure is actually achieved in the automatic level. So I understood there was some question about efficacy with that.
I think that's right. Not every automatic machine is the same, and I guess the Australian ones, progressively become better and better at recognising events and at adjusting the pressure. Some of the early ones were very difficult for patients to manage, and were good in some patients, but not for everyone. But they're getting progressively better and better. I guess with this, you just, as we said, we don't know.
A big problem I have is, you ask what else can GPs do. We still shouldn't give up on weight reduction, exercise, lifestyle changes. And the big thing we sometimes can look at, I mean, we can't change their weight, we can't change what they eat, but we can change their drugs. A lot of the people, by the time they get to this stage, they've been depressed for many years, they're on benzodiazepines, they're on antidepressants, they're on this. And there are some drugs we should definitely try and stop. Narcotics would be one of them. I think some of the antidepressants, it would be good if we could stop those who have a sleepiness factor. But the benzodiazepines, it would be lovely if we could stop them, I think. Are there any other drugs we should try and stop, perhaps?
I guess, so just to expand on that, so certainly medications are really important. And as we mentioned before, some of these people can present with insomnia rather than with sleepiness. And so it's very, very common that they've had multiple different medications. A lot of the older antidepressants are very potent REM suppressants as well, so that can be an issue for sleep in itself, but also it can make it very difficult sometimes to interpret the sleep study. But anything really with sedative potential we should be looking at. But lifestyle that you mentioned, weight is phenomenally difficult, but we've all seen patients where they've had significant sleep apnea initially and have managed to lose a substantial amount of weight and have gone from being significant sleep apnea to being quite mild and maybe not needing Cpap treatment, just needing observation. So they're rare, and we like to trumpet those when we see them, but we do see them from time to time. But also things like sleep hygiene, making sure they get plenty of time for sleep, a regular sleep pattern, correcting sleep phase disorder if they've got it, avoiding caffeine in the afternoon and evening, which I'd find incredibly hard to do. So there's a lot of other things that we tend to sort of skip over and move straight to Cpap when there's a lot of other things that need to go with it as well. Absolutely right. And
do you find that starting treatment with Cpap actually helps patients to lose weight?
We'd like to think so. Unfortunately, the evidence is not so supportive of that, and that it probably stops the progressive weight rise that we see. But as for losing weight, it's very difficult, and it's not just the sleep apnea. We don't know how to fix the metabolism, and as they're more sleepy, they're more inclined to eat and to do less. So becoming less sleepy can certainly help from that. But weight loss is a very complex thing, and it's not. I don't think it's just as simple as just Cpap, unfortunately.
What about the audience? Are there any questions for our panellists tonight? No, very quiet.
Can I just make one comment?
Yes, absolutely.
Because he has the case study up there, and because this has happened this week, it's very fresh in my mind with a pneumonia patient who is actually a sleep apnea patient. And I think it's very important for us to look at when inpatient management, so that if we're actually bringing someone in and they do have pneumonia, that their Cpap should still be maintained and their oxygen should actually be entrained into their Cpap, and that there are adapters that are available very simply, and we should have them at every site. Instead of just attaching, well, you don't really and shouldn't attach oxygen tubing or nasal prongs underneath the interface or under the mask, but actually an adapter put on to the in between the actual tubing and the mask, or at the machine level, is vitally important in the management of these cases.
And a lot of the masks have a pressure monitoring port that if you're stuck you can just put the oxygen directly onto
it. So, yeah.
If you're faced with that, say, in a rural health centre and you're admitting a patient with an acute pneumonia, but you feel you can manage them rurally, but they do say, oh, I usually have Cpap at night time. You know, if you've never seen a Cpap machine before, do you just pick up the phone and call, or who do you call?
The patients will often know more than the doctors in a lot of those situations. Yeah, if they've been on it for a while and have been through processes like this where they've been well educated, then often they will know exactly what they're doing, and they can often advise you if you're not sure. But otherwise, you know, a simple phone call is, you know, all the advice is as close a phone call away.
We are quite regularly now even putting oxygen adapters, so for people who buy masks that don't have adapters, we'll actually be putting adapters with their purchase, so that for rural areas they likely will have it. Well, not just rural areas, trust me, metropolitan here, it's not just rural areas, they'll actually come with that adapter.
But that
And
advice
and like there's always contact at overnight sleep labs. So when you think about it, people are actually doing studies in some of these other labs. So therefore, there is a service there. So if you want to ring one of those labs, they may well be able to help for the patient set up.
Great.
Yeah. I was just going to reinforce that advice of actually reminding people to bring their Cpap when they go to hospital. So if they are going down to Brisbane for their surgery or something else, to remind them to take their device with them. So particularly for after anaesthetics, but for any admission, they should take it. You'd be surprised how many people come to a sleep clinic for to check their machine and don't actually bring their Cpap.
Aeroplanes actually have, airlines actually have spots for CPAP. Unfortunately, people who like to travel first class tell me it's right up the back of economy, and they don't like it very much. So they tend to stay awake for their flights.
I haven't been in that part of the plane yet, but I'll look next time.
I'm sure we'd all like to know what happens in first class.
Yeah, we would.
Well, thank you very much for that discussion, but unfortunately we are out of time. So thank you to Jamie for your excellent case presentation, and thank you to our specialist and expert panellists for their extremely valuable contribution to tonight's discussion. I'd also like to finish with a special thanks to the support of the Digital Media Services of USQ. Well, that's it for another excellent Grand Rounds presentation. The next Rural Medicine Grand Rounds will be on Thursday the 6th of November, and we will be exploring cases in endocrinology and renal disease. We look forward to having you join us then. Good night.